Welcome to Hospice 101, a webinar presented by Mollie Lust of Allegheny Health Network, Healthcare at Home. I am Casey Peluso of Parkinson Foundation, Western Pennsylvania. Thank you for joining us. And I'm delighted to introduce you to our presenter today, Mollie Lust. She has been working in the elder care 65 plus field for 15 years. She's been working in the hospice field for 10 years. Mollie is currently the Regional Director of Sales for Allegheny Health Network, Healthcare at Home Hospice. She started her hospice career as a social worker, and her roles have expanded throughout the years. Now she's working more so on the business side of hospice. And she's been with Allegheny Health Network for 5 years. She runs the team on the ground in Pittsburgh and also works with partners in northeastern and eastern suburbs of the greater Pittsburgh area. She's also passionate about educating people about how it can be beneficial. So, Mollie, I'm sorry.
You're fine.
Mollie, please take it away. And thank you so much for presenting on such an important topic.
Absolutely. Well, thank you so much, Casey. I appreciate the opportunity to be here. I'm so excited to share with you all a little bit about hospice today. We're going to do a full 101. So we're going to go from the development of hospice, where it came from, to where we are now, and then how to utilize and get into the benefit. Like Casey said, please don't hesitate to ask a question in the chat box, or to, just unmute and ask a question. I want this to be interactive. There's no reason I don't have to just info dump. I'll certainly be happy to share and talk and discuss with you all. And then again, as I said, as Casey mentioned, there will be time for questions at the end. So as Casey mentioned, I've been in hospice for a long time. I've been working in this industry, like the 65 and older community or care industry, for a long time. Although those of us who are in the 65-year-old range don't always want to be added into that large group beyond that, where we get a little bit older. But I've been working with what I would consider elder care for a long time. I started out as a social worker in nursing homes, and then eventually transitioned into hospice social work, where I really found my passion. And as Casey mentioned, I am extremely passionate about educating folks about hospice, palliative care, what the differences are, and how hospice can help people. Studies show that if you take two people with the same disease progression and comorbidities, and you give one person the hospice benefit and another person chooses not to utilize the hospice benefit, the patient with the hospice benefit tends to live almost 63 days longer than the person with the same exact disease progression without the intervention of the hospice team. So you can see why I think it's incredibly important to share the information about hospice with everyone and continue to encourage people to utilize and access the benefit sooner and talk about the benefit. What does it mean? What does it look like? Those of us in Western Pennsylvania are in the lowest utilized area of the entire United States for hospice. So it's important to educate and shout it from the mountaintops every chance I get to talk about what a great product hospice is and how it can help folks. So like I said, we'll get moving here, but thank you all for being here, and feel free to ask questions as we go along. We're going to talk about the history of hospice and hospice fundamentals. And I'm going to move this screen over a little bit so I can see it. There we go. So hospice is a relatively new concept. It has probably been something we've all done for a long time, where we've cared for elders for generation and generation and millennia. The actual idea and concept of hospice is relatively new to the United States. You see here, I focused on a name here, Saunders. That's Dame Cicely Saunders from the UK. She was sort of the modern mother of hospice in creating the full concept of what that care looks like, a place to provide that care, and then ultimately bringing that concept to the US. And she brought that to the US at Yale University and started to share and educate what that looks like for folks. The first modern hospice was actually St. Christopher's Hospice in the UK. Not too long after, you can see how the progression of this goes quickly. From 1963 to 1967, 1969, Dr. Kubler-Ross published the book on death and dying, which is still fundamental in teaching about the concept of hospice care. And quickly after that, Hospice Inc. was founded in the US, where Florence Wald, who started the first hospice here, pioneered the concept of the IDT, which is actually the interdisciplinary team. Hospice is a full team approach to patient care. So that was initially founded here. And then 1974, it was founded by Florence Wald, 2 pediatricians, and a chaplain in Connecticut. So you can see 1974, that's not that long ago, that we really had the first modern hospice in the United States. My next screen going here. There we go. The Medicare benefit for hospice was made permanent in 1986, and states are then given the option of including it in their Medicaid programs, which almost all states have included it in their Medicaid programs. And then in 2008, the conditions of participation, or our regulatory standards that we follow, are significantly revised to what we know today. You may hear me eventually discuss how hospice is perceived now versus how it was previously perceived. This moment in time in 2008, when the conditions of participation are revised, is when Medicare opened the guidelines and broadened the gate, so to speak, to allow more people to utilize hospice. And so from there, we working in hospice have been doing everything we can to share with folks, hey, the gate's open. It's an easier way to get in. There are easier ways to get in and utilize all the care that you're given at home. And by the way, it's paid for by the government, so take advantage of it. We've been working to share that message out to everyone. And 9 times out of 10, once we get someone who's utilizing the benefit of hospice, they or their families will tell us, man, I wish I would have known sooner. So that's one of the reasons I want to share with all of you, to share more about this with all of you today. So what we want to talk about is hospice as a philosophy. Hospice can be engaged in several ways. In some states like Florida, there are hospice homes that you go to that a patient may move into when they admit to hospice. Pennsylvania doesn't really have any hospice houses, so to speak. There are some areas and different floors on hospitals and nursing homes where patients can go when we are truly in a very end of our life or terminal phase. But hospice is not only a place or a care that we provide, it's a philosophy. In fact, most hospice service takes place where the patients live. 67% of service is provided in a patient's home. If you're looking at Allegheny Health Network, I want to say 88% of our patients are home patients, meaning we are the primary caregiver for them in their home. The other percentage of our patients we interact with in nursing facilities and personal care homes. Hospice offers an interdisciplinary team approach to treatment and care planning for patients. We want to attend the physical, the emotional, psychosocial, and the spiritual aspects of dying and caregiving. I often talk to people, 5 times a day as they're getting ready to come into utilizing the hospice benefit, or they're getting ready to sign up a family member on the hospice benefit. And one of the things I often tell them is, we're going to take great care of your mom, and we're going to take great care of you. It's just a natural part of the caregiving process that the person caring for the patient is also going to receive care from our team. Okay. We focus a lot on quality of life and quality of death, and we view death as a natural process of living. It's something that is going to happen. It's something we all don't like to talk much about, but if we can focus on quality in that process, we can make that process go well. Our goal is to affirm life. I want to highlight that here. Our goal is to really affirm life, and we don't hasten or postpone anything. We just affirm what is happening, the physical, mental, and emotional symptoms that happen as we continue the process of living, and we continue on toward a terminal diagnosis. And we don't do anything to speed or postpone that, but we affirm it. We determine the things that are specific to you that bring quality of life to a patient, to the family. And what we like to highlight is we include the right to die pain-free and with dignity. We encourage our patients to complete advanced directives, and we honor those choices. You get to make the choice regarding resuscitation measures, curative treatments, anything else on the pink. If you've seen the pink post form, or you've filled out a DNR, or you filled out any sort of advanced directive, you've seen what those are. And there's generally more than just an elective for a DNR or not. All of the choices that you make for your directives for your healthcare in the future are honored. And one thing I always like to make sure that people know is that you do not need to have a DNR in order to elect hospice services. You can come on to service and still have a wish for resuscitation. There may be a point in time as you work with our care team that you change your mind, or that we educate on what CPR does to a 90-year-old body versus a 20-year-old body, and that you may not change your mind, and that's okay. We honor the choices of our patients. Okay. One of the things I find very important to discuss is the difference between palliative and hospice care. Everyone gets the words a little bit confused. People keep telling me, oh, you should just change the name to palliative care because people are scared of hospice. And I understand, but I do think if we change the name to palliative care, people would be scared of palliative care in about 10 years anyway. What's important though, is to understand how they're similar and how they're different. I like this top point here. All hospice care is palliative, but not all palliative care is hospice care. Palliative care programs include curative treatment, curative care, continuing to seek out aggressive treatment for a disease process. The important word here is curative. Palliative programs focus on what can we do to cure or right the ship. It can be reached by or received by patients at any time, at any stage of their illness, whether that stage of their illness is terminal or not. Sometimes palliative care programs are initiated in an inpatient facility, like you may have at some point a palliative care team in a hospital or a nursing facility addressing a patient and saying, here's where I think we can go and work on your symptoms. There's no life expectancy requirement, and they don't provide the same range of core services that hospice provides. Palliative care is often a palliative physician and a nurse. And hospice, you'll see as we go further into discussing the benefit, it has a much larger team involved. Not that that's a bad thing under palliative care. They just are not required to give the same benefit. The hospice care benefit is a Medicare benefit for the terminal phase of life when the cure is no longer possible. One way I tell people to think about this is if we are optimally treating a patient, we're doing everything we can for their cardiac disease, and we've thrown the book at the disease process, but they're not a candidate for surgery now. There's not a candidate for a transplant. And we've done everything else that we can that we think we could do. And now we are in a phase where we're just going to maintain and maybe tweak meds here and there. And there's no longer a probable cure for this patient. At that point, we can start the discussion of how can hospice support you? You don't necessarily have to be in that 6-month process, but that's a great time for us to start, is when we know we've optimally treated the disease and the disease is still progressing. One of the things that people highlight with hospice is the 6 months or less life expectancy. Now, that's really hard to say exactly where we're at with a 6-month or less life expectancy. None of us has a crystal ball. None of us are excellent at prognostication, being able to tell what's going to happen in the future. But here's the way I frame it for physicians and for caretakers, patients alike, to understand what we mean with the 6-month or less life expectancy. So think for a minute of a patient with a disease process where we've hit the position where we have optimally treated it, but there's nothing else that we can do aggressively to cure this process. That might be someone with COPD or CHF or Parkinson's, and we'll discuss that down the line here. But let's say for simplicity's sake, someone with COPD, which was an advanced lung disease. They have oxygen, they have dilators like inhalers to help them breathe better. They may have a private duty aide that sets them up for lunch, or a family member that brings food over, sets up for lunch, and then does laundry for them. They have a lot of social supports, and then they have the support of their physician and their medications. If we look at that patient and say, let's take away the social supports, and they're on their own in their apartment. They have to set themselves up for all meals. They have to do their laundry. They have to, manage all of their grocery shopping and what have you. And then take it a step further. If we took away their medication, their oxygen support, their inhaler support, what would they look like in 6 months from now? If the answer is pretty rough, then that's the beginning of us being able to say we may be at a 6 month or less life expectancy. Now, I don't want you to think that when hospice comes in, that we take those supports away. In fact, we're an additional layer of support on top of all of that. But really for us to look at a disease process, to identify where a patient is in the disease process, if we look at everything that they have supporting them in a day-to-day function, and we say, where would they be without this? We can start to identify where they might be in 6 months, where they might be a year from now. Okay. Hospice care addresses physical comfort and symptoms, and we address emotional and spiritual concerns about dying for the patient and the family. We have counseling teams that are just an initial part of every patient's care team. We have the full IDT, which I'll explain to you, as a physician, a nurse, a chaplain, a social worker, and an aide. All of those team members are trained, but the chaplain and the social worker specifically work very closely with families to engage conversations about any concerns that patient and family have. They may not have concerns, or they may have concerns or time for life review or other conversations that are important to have at this phase in life. And our team is there to help facilitate it if families want. Some families aren't really ready or ever open to having those conversations, and that's okay. But now at this phase where we are encountering patients is a good time for us to at least open the door to those conversations. And our team is highly skilled and trained in helping families to have those conversations. Another easy way to remember the difference here between palliative and hospice is that palliative care programs fall under Medicare's home health benefit. Palliative and hospice cannot ever be given together because they come from two different buckets, essentially, that Medicare provides. Medicare puts a bucket of benefit aside for home health and palliative care, and everything in that region is paid out under this bucket of care. And then hospice is paid out from a completely different bucket or benefit here. Okay, so they're both a Medicare product, and they're paid for under two different parts of Medicare. Computer's a little bit slow here today. There we go. When should someone elect hospice services? So according to external research, patients and families really get the full benefit of hospice services when we start hospice on board at least 2 to 3 months prior to passing. Although I would recommend much sooner, 6 months, 9 months prior to that, if we have agreed that we're no longer seeking a curative treatment for families. The reason I suggest that is our first priority is maximizing comfort and decreasing pain. That is something that we can do really well when we know someone at a stable baseline, and then we're able to help as there are declines in their disease process. We're able to help and jump in and know them really well from previous. We're able to provide some counseling, attend to closure tasks, which might include putting affairs in order, saying goodbye, having important conversations, mending relationships as necessary. It can be something as simple as just a life review. When I was a hospice social worker, I had a patient who was a World War II veteran, and my grandpa was a veteran of World War II as well. He was, in fact, provided support at D-Day. And I always have such an interest in World War II. I'm sort of a history buff. So I started a conversation with this patient as he sort of brought it up, and I asked him questions that were specific. And he looked at me and said, "Oh, did you know about that?" And wanted to talk a little more. And that ended up blossoming into this wonderful relationship where every Wednesday I would take him and his daughter donuts and coffee, and we would talk, and he would share more about the war and what his experiences were. And one day his daughter walked me out to my car and said, "He's never shared any of this with us. We didn't even know the questions to ask to get there. We just kind of respected and gave him space." And I told her there's often times where people aren't ready to discuss things or have conversations regarding, significant events in life until a certain point in life. And for this gentleman, he was at a point in his transition and his journey that he was ready to have that conversation. It was hugely meaningful for the family and very meaningful for the patient as well, to be able to share these stories and have his story honored. That's one of the things that having time of being on hospice will allow for patients and families. We also recommend that it's important to have a straightforward conversation with the doctor about end-of-life issues. It's important for us to know if I take the road of seeking out an aggressive treatment and a trial, and I look at that road, or I look at this road over here and say, I'm not going to go for a trial treatment that I don't know will help. And if the end game is the same in 6 months, regardless, it's important to know that, have that conversation with your physician. Where can I really go with this? How can I get the most out of most quality out of my time? And talk with your doctor about what that looks like. Doctors truly are curative people. Their goal is to cure and continue to care for patients. And by all means, they should do that. But it is important for physicians, patients, and families to have straightforward conversations about these issues and to really understand, like I said, none of us have a crystal ball, but if I do this versus this, will the outcome be the same? And then continuing to build that relationship with your physician so that you can make a decision that they honor and that you're ready for. Okay, hospice eligibility comes in under Medicare Part A. The doctor must certify that you're terminally ill with, and again, this life expectancy of 6 months or less. But again, remember, this is something that is really hard to guess. So that's one thing we'll do is have a nurse come out and meet with the patient and family, go over an extensive history for the patient, looking at past medical records, lab testing, etc., and understanding really where someone is in their disease process, okay? Another criteria would be being willing to accept palliative care for comfort instead of curative care. And then, of course, for someone to be eligible for hospice, you sign a statement electing hospice care, which is one of our consent forms that we do for folks that all of the hospices would do. So hospice care is given in benefit periods. I wonder if any of you have ever heard of someone who graduated off of hospice or was, quote, kicked off of hospice. Understanding the benefit periods may help you understand why those things have happened in the past. So a doctor certifies each benefit period. The first 2 benefit periods are 90 days, which is essentially equal to 6 months. In that time period, in the first 90 days, we have to demonstrate that patients have continued to decline in their disease process. That could be something as simple as they're sleeping more, eating less. It could be that they didn't need as much care with a shower when I first engaged them 90 days ago. And now I'm really, as the aide, integral into their showering and bed bathing and making sure that their activities of daily living are staying on track. They rely much more heavily on me or a team to do that. It could be having an infection or a fall or, a lot of medication changes, those sorts of things. After those first 2 90-day benefit periods, a patient enters what you would consider an unlimited amount of 60-day benefit periods. But after each 60-day period, we have a face-to-face encounter with a physician or a nurse practitioner that the team manages for you. The patient doesn't have to leave home, but a nurse practitioner comes home and meets with the patient and family, goes over the documentation of what had been done in the previous 60 days, and then is able to certify that the patient can continue care. Or if there hasn't been continual decline in the disease process, there may come a time where a patient would graduate off of services because they've stabilized and then are able to come back into service. Now, remember, it's unlimited benefit periods. So once there's a decline again, a patient can come back into hospice services. But there have been times, and you may encounter folks who have told, oh, they took my mom's hospice away, or my mom graduated off of hospice. What that really means is there wasn't enough of a decline in the disease process to justify to Medicare that patient continued to need the benefit of hospice. I will tell you, there are definitely times where we see someone and they're not looking extremely well, but then you take a course of routine intervention at home. So a nurse and an aide in home multiple times throughout the week, medications being delivered to them at home, a nurse and the aide setting medications out and reminding patients to take their medicine. And suddenly we see them stabilize in the disease process because maybe they have been significantly on their own trying to manage that. And that's pretty impossible to do on your own sometimes. When you have a care team that's kind of staying on top of all of your care, you may stabilize and come off of the benefit for a while until you decline further again. So there's different ways that we engage it here. But what's important to know is it's unlimited. So if you're, let's say you come off of hospice benefit because you wanted to go to the hospital you fell and hit your head and wanted to go to the hospital, you can come back into a new benefit period when you come home. Or if hospice says, hey, you've stabilized enough and we can't continue to justify to Medicare to see you, then you can come off for a while. And if you decline, come back on. Okay. So it's unlimited. You can use it at any time. So hospice team is your primary provider of care once you join into the hospice benefit. I like to tell people to think of it as a doctor's office on wheels or a mini contained hospital on wheels. Our nurses are extremely clinically capable. In fact, to be a nurse for Allegheny Health Network's hospice, you have to have at least 10 years of nursing experience before we would be able to even interview for the job. Because our nurses have to be self-contained mobile physician units going around seeing, 5 to 6 patients a day in their home, providing care, knowing what to do on the fly. This thing came up, or there's a wound that I need to manage, or there's some medications that need to be changed. The nurses have to be able to be self-contained to do that. They can do catheters, IV fluids. We can even do some pretty aggressive cardiac medications that are delivered via IV at home. So we provide comprehensive coordinated care for patients, and the nurses really are like a care team on wheels out to you. Once you choose hospice care, your hospice benefits cover just about everything you need, including any medication related to the diagnosis we're seeing you for, your supplies, which would be gloves, wipes, briefs if someone is incontinent, things along those lines, and all your medical equipment. A lot of times I'll talk to families and say, I can get you anything up to a mechanical lift, a hospital bed, et cetera, at home, and get you all the support for that. And people think, oh my gosh, how much is this going to cost? It's covered by your Medicare benefit. There's no cost for the provision of hospice care to any patient. So it's pretty shocking to families when they realize how much we offer and what we're able to provide for them. And this is across the board. All hospices offer all the things that I'm sharing with you now because we're a federally regulated benefit. But you shouldn't really need to go outside of hospice, your hospice team for much, because we get a lot of it to you. The medications that we order and that we cover for patients are delivered to them at home as well. So it's a really nice benefit. You don't really go outside of your team to get hospice care, although there are times, you come on to hospice for one certain diagnosis, but you're still seeing a dermatologist for another diagnosis. Or if you come on hospice for a diagnosis of COPD and you're still seeing a doctor for glaucoma or CHF or some other disease process, you're able to sometimes see other physicians while you're on hospice, but you don't really have to if you don't want to. We can provide everything that you need at home. We have nurses and doctors on call 24 hours a day, 7 days a week. The way we set our team up is that we have case managers who see patients in their homes routinely throughout the week. And then we have fully staffed night teams and fully staffed weekend teams that are always there to support families. And we have nurses who answer a triage line 24 hours a day as well. So you could pick up the phone at 2 a.m. and say, oh my gosh, my mom's on your hospice care and she is just having incredible pain that I can't manage. What could I do? And the nurse on the line will give you some suggestions. And then at the same time, we'll be sending a nurse out to see you at home and support you at home. Okay. If at any time the hospice team determines that your care needs are exceeding the care that they're able to provide at home and that you need inpatient care, the hospice team makes arrangements for that stay. They contact the team that would be caring for you, and then they provide visits in the facility, wherever that might be, whether a hospital or a nursing home. And they work with that team until we stabilize the patient and bring them back home. Okay. And I sort of mentioned this before, but these are the core services that hospice provides directly to patients. We provide a hospice physician Some teams have just one physician that manages their entire hospice. The way that we at Allegheny Health Network are set up, that we have a medical director who manages everyone. She's the director of the doctors, so to speak. And then each team that we service, so we have 7 different teams throughout the region because we cover 6 different counties. Those teams all have their own medical director that those nurses call specifically. That way, one nurse or one doctor isn't getting phone calls for 400 patients. We spread that around to about 6 or 7 other doctors. You're also provided with nursing care, which includes an aide. So you have an RN, and all of our nurses on our team are have additional advanced practice degrees or certifications, like palliative and other nursing certifications. We also all provide social work and counseling services, which includes pastoral care. Now, I always like to highlight our pastoral care teams are non-denominational. They work with folks that might be any variety of Christianity, Catholic, Lutheran, Methodist, etc. They also work with folks who are Muslim, Buddhist, Jewish. Anyone of any stripe is welcome under hospice care, and our pastoral care teams are really well versed in how to provide care for those folks. In fact, it's really important for us to know culturally what a patient identifies as religiously, so that if and when a patient passes on our services, our team is able to provide the most culturally appropriate care. There might be some times in which a patient, once they pass, their body is only to be touched by the women of that community, or only to be touched by men of that community, or only prepared by someone in that community. It's really important for us to know that and to honor that for folks. And so that's really where our pastoral care team comes in, is understanding those cultural importances and sharing that with the team. We also provide bereavement services for 13 months after a patient passes. Now, it's certainly not required that a family member would utilize those services after a patient passes, but we do follow for 13 months so that we get past all the first birthday, Christmas, etc. beyond that. And then if someone would like follow-up post the 13 months, our bereavement team is more than happy to keep them on and stay in contact with them. That can include in-person and virtual caregiver support groups or bereavement support groups. We do services quarterly for those that have passed. So I always attend with the chaplains and the social workers and the other team members there, and different ways for families to express and have their grief and emotions that have, you know, from the beginning to the passing of the patient, to have those feelings honored. Other services that we provide at times are therapy, hospice aid services, or home health, as I mentioned, and volunteer services. Some patients who come onto hospice benefit from and need therapy services like physical therapy and occupational therapy, and we're able to provide that. One of the instances it's very important to do that is if someone's been in the hospital or at a nursing facility for a long time and they transition home with our services. It's really important for us to have a physical therapist in the home with the family for several visits to make sure they're transferring someone appropriately, helping them get up and move around appropriately so that the caregiver stays healthy as well and doesn't have injury. Okay. Volunteer services are actually a federally required benefit of hospice. So there's a certain percentage of your care that has to be done by volunteers every single year. And if you can't qualify or prove that you've done that, then you do have to pay Medicare back some of the money that they have paid you out. So volunteer services are absolutely a requirement for all hospices to provide. There's 4 levels of hospice care. The 2 levels of care that you hear or see about most are routine, which is the top here. It's most common. The patient is at home, and that might be a physical home, a nursing home, a personal care home, whatever that looks like for them, where they're receiving the care of the hospice team. Okay. The next level of care that you really hear the most about is general inpatient care, which is a really high intensive level of care, and they have to be in a hospital or a nursing home to receive care there. Though it's really only done in instances where, like I mentioned before, if your care needs exceed what we're able to provide at home, we would work with a team that can provide 24-hour support while we come in and provide, continue to provide care planning and coordinate care with that intense level of care in addition to our team. Okay. The other two level of care is not really something you hear much about, although respite care I will mention is it's a caregiver benefit. And that is for folks that are, providing care for patients at home. It can be really taxing on you physically. It can be very taxing on you mentally. And there may be times where for a vacation or a caregiver gets sick or they need to travel to their child's graduation or something, that we would work on finding an inpatient respite for a patient. It's 5 days in a nursing facility paid for by Medicare. We coordinate the transportation and it gives the caregiver some relief or time to travel and do what's necessary for them. Our team continues to provide care to patients while they're on respite care. Okay. Hospice covers, or excuse me, Medicare covers hospice and skilled nursing facilities. We can contract with any facility in the area, and they can also, as I mentioned, do some short-term inpatient care. I'm not going to read the whole slide about revocation, but it's important to know that at any time you may revoke or end the election of hospice care for any reason. It might be that the patient fell and bumped their head at home, and we want to really make sure we know what's going on with them. So we send them to the hospital and they revoke services while the hospital is providing care for them. And then they come back to our care when they come home. It might be that families dip their toes into the water and said, okay, let's give hospice a try. And then they realize, what's all involved. And they decide, this really wasn't for us. We're not quite ready for this. And they decide that they want to seek additional curative treatment. They can make that decision. They can make the decision that they don't want hospice for whatever reason, and they're able to revoke or end the care. Okay. Your typical insurance that you had prior to utilizing hospice would then pick up and continue to provide your care at that time. So we'll talk a little bit further about hospice criteria. I'm going to take a look at the time here. So about 20 minutes left. I'm going to go for about 10 more minutes and then leave 10 minutes for discussion, questions, conversations. So I'll just hit the highlights on some of these. But we'll talk a little bit about disease progress or disease trajectories and the criteria for utilizing hospice if you qualify or you have a family member that qualifies under any of these diagnoses. So a poor prognosis with a terminal illness, physician-directed plan of care, acceptance of palliative care, and then of course the signed statement, which is electing hospice from a patient. That's to qualify if you remember from previous. We kind of discussed a little bit about this life-limiting condition, meaning that we've optimally treated a disease process and the patient is still declining, okay? The doctors continue to find the qualifications for that and show the prognosis. And we would see that there's a progression, a clinical progression of their disease that's evidenced by several things listed under here. Multiple physician assessments. We can see labs. We can see the progression of disease as we look at labs from January, from March, from May, and so on. We can see how that changes. If the patient has had multiple emergency room visits in the prior 6 months or multiple hospitalizations 6 months prior to the recommendation of hospice, we definitely know that there's something there that might qualify them for the use of the hospice benefit. And the home health, if someone is receiving home health care and their nurses start to recommend like, hey, I think that your care needs are more than what really home health can provide, that's another way for us to look at that clinical progression of disease. Over here, you'll see the word P or the initials PPS. That's a palliative performance scale. And I won't get too far into the weeds on that, but you can certainly see that if your palliative performance scale is at 50% or below, meaning you need a lot of help daily to live, or you live sort of a bed to chair existence, that we're able to look at potentially qualifying you for that entry into the benefit. If they have an impaired nutritional status, if their albumin is along these lines here, we don't need to get too deep into the weeds on this, but if their albumin is low and continues to be low, that might indicate to us that there's something going on with the patient there. And then other declines in functional status, like dependence in 3 of 6 of your activities of daily living, which are noted under there: bathing, dressing, transfers, continence, things along those lines, ambulating to the bathroom. Karen, that's a great question. I see your question here. Requirements or qualifications to be a hospice volunteer. That's such a great question. The only requirement is a little bit of time. So we will certainly, hospices, because the volunteer benefit is a federally required part of hospice. We do have to treat our volunteers like employees. So you have to go through orientation. You have to be willing to do a TB test to prove that you don't have TB, which most of us don't, but you have to get the little poke of the skin to prove that you don't have TB, and go through our orientation program in order to get assigned to an aide, or excuse me, assigned to a patient. So it takes just a little bit of time, but it's really well worth it to make it through the orientation and what have you. But that's all you need, willingness and time. My screens are sleepy here. Let's see what our next chat. Absolutely, Karen. Thank you for the question. That was great. So I mentioned a palliative performance scale a little bit ago. So this is what it sort of looks like. Most of us here fall into the top part. We have normal activity and work, no real evidence of disease process, or we have some evidence of disease, but we're all living sort of a full ambulation, full self-care life and what have you. And then you can see as it continues throughout the scale here, at 50% or below is when we start to look at someone might qualify for the hospice benefit. Unable to work, extensive disease, you need considerable assistance to ambulate and move around and have your self-care. If your ambulation is mostly that I'm sitting, or mostly I'm in bed, or they're totally bedbound. When we hit 30 and below, it's really a time for looking at hospice and having a full conversation about it. But here at 50% and below, now some of us may look at that and say, oh, I mainly sit down and I don't do a whole lot of work and I do need help. It doesn't necessarily mean you're ready for hospice. It just means it might be a conversation to talk about for several years in the future. Once we get here to 30 and we're totally bedbound and you need care for all of your activities of daily living, it's really time for us to have that conversation then. We're going to skip past that. And here we see the FAST scale, or our functional assessment tool. It helps us really know where we're looking in addition to our palliative performance scale. And you can see here, most of us are here again at the top, that we're no real difficulties, or we have some forgetting of objects. That's me. I put my son's toast in the refrigerator the other day. I don't know how or why. So I'm at a stage 2 here, apparently. Decreased job functioning that's evident to coworkers, although I could probably fall under that as well. But once we really get down into the lower 6s and 7s is when we look at qualifying a patient for hospice. That's where they have incontinence more frequently or complete, and then limited ability to speak, limited ability to walk or ambulate, even the inability to sit up without assistance, or even losing the ability to smile, which is oddly something that we do utilize as a staging tool. That's really where we start to look at. So I'm going to get to a couple of considerations for a couple disease processes that we see here in Western Pennsylvania, and we'll specifically touch on Parkinson's. But I wanted to show you 2 disease considerations first before we hit onto Parkinson's, because hospice, nothing's black and white with hospice. It's really difficult for me to say we always do this care plan or we always do that care plan for patients, because everyone's different. We look at a holistic person. Someone might have a disease process that affects a different organ one way, and someone else may have something that affects it a completely different way. So it's important for us to look at the whole patient. And excuse me, you may hear my dog in the background here. She thinks it's time to go out, but I think it's time to continue talking about hospice. So pulmonary disease considerations would be, so someone with COPD and other breathing issues. We would look for severe lung disease marked by disabling dyspnea at rest, meaning shortness of breath, being hypoxic at rest on room air, meaning having a lower oxygen saturation on room air without the use of oxygen, progression of pulmonary disease, multiple visits to the hospital, and potentially right-sided heart failure. So if you're looking at someone with cardiac disease, what we're looking at is an ejection fraction less than or equal to 20%, meaning the amount of blood that your heart is able to pump and the amount of percentage. Most hearts are pumping at 80 or 90%, really getting blood moving through the system. If we are functioning at 20% or lower, we're pretty much ready for the conversation of you could benefit from hospice here. There are a couple other things here, but what's most important to know is a low ejection fraction, and then a history of cardiac arrest or a history of syncope, which would be like fainting or whatever as a cardiac cause. Okay. So just a couple on each of those. And then we get to Parkinson's disease. And Parkinson's disease can be difficult to qualify for because it's a very case by case, again, as we evaluate the whole person. But these are the things that we look at: a progression from independent ambulation to wheelchair or bedbound status, progression in intelligible to unintelligible speech, from a normal to a pureed diet, a transition from as activities of daily living, a transition in the support needed for those ADLs, and nutritional impairment. We also look at other complications like infections like aspiration pneumonia, sepsis, upper respiratory infections, UTIs, recurrent fever and antibiotic therapy, and then pressure ulcers. Those are all sorts of things that we look at. And we also can then qualify, folks with Parkinson's if they have some sort of Parkinson's type dementia or other disease progression that continues to impact their Parkinson's disease as well. Okay. One other slide I wanted to show you. So this is one of the programs that AHM will be rolling out shortly here, which is a good question of, is it time to consider hospice for patients with Parkinson's disease? And the way we can think about that is the acronym MAPS, Management of Advanced Parkinson's Symptoms. And you can see here that we're looking at physical comfort. Are we using a variety of medical and non-medical interventions for addressing non-motor symptoms like pain? Are we looking at delivery, medication delivery methods for effective symptom control? Emotional support, including treatment for depression and other psychosocial issues common among Parkinson's disease patients. We would look at engaging therapies like music, aromatherapy, legacy projects, etc. Planning for the end of life. That's a great time to start having conversations when we've advanced in that disease progression there, to really start those conversations. And then if you think that you're looking at someone with the diagnosis and you think the companionship and the non-medical assistance that they would get from that team would be really beneficial, then it might be time for a friend, caregiver, family member, physician to say it might be time to consider the conversation for Parkinson's disease, as we continue to look at the progression of a disease process. Okay. There are a couple others here, and I can go over them if there's anything specific, but we have about 10 minutes left. So I'd like to open it up for questions, comments, stories, any sort of question that you may have. Feel free to jump in and ask or put them in the chat box. I know I threw a lot of information at you all here. It's a lot to consider, a lot to talk about. Maybe I've overwhelmed you with all the information.
Hey, Mollie.
Comprehensive.
Yeah, go ahead.
This is Karen. I wanted to stress how important it is when you said I find it interesting that you use the term crystal ball. That's one of the reasons that even with palliative care, people need to start investigating those kinds of things, because when it winds up being a crisis situation, I've heard from caregiver meetings that I had to show these people where everything is at. It takes time for people coming into your home to learn. They don't have crystal balls to know where you keep the water glasses, things like that. And really, it shouldn't be something that people should be afraid of. It should be something they should embrace, because it is such a valuable service.
Absolutely. Thank you for bringing that up, Karen. You're 100% right. It's when we think back to that time in 2008 where Medicare broadened the horizons to get in, they didn't really do a great job of sharing that information broadly out to everyone to understand. Now hospice is it's like a medical team on wheels that comes to you, rather than something we utilize when we have cancer or we're the very end of a terminal process. But the earlier we engage, as you mentioned, the more comfortable the caregivers are in your home who are able to care for you, provide really great care for you. They walk in, they pat the dog on the head, they maybe throw some food in the cat bowl for your cat because they've known them for 6 months and they've helped out in the home. They might build a relationship with your grandchildren or other family members that they can then extend, beyond your care and support them in different ways. But you're 100% right. The earlier you utilize the benefit, the better off everyone is and the better care that you receive. Is medication still administered if the patient is in palliative versus hospice care? That's a great question. Medication is administered under both palliative and hospice. There's sometimes a consideration or concern that hospice will come in and we're just going to stop all your medications. And that's not how we approach things anymore. That might have been what was done previously, but that's really not best practice. And I think maybe have found that out via trial and error. But for the 15 years I've been working with hospice care, and then the 10 I've actually been in hospice, we don't do that. There may be times where we come in and say, oh, this vitamin D that you're taking, or this vitamin there, or supplement here might not be helpful, or might be hurting your stomach when you take it with this other medication or what have you. But if you're on a cardiac regimen and we're seeing you for Parkinson's disease, or we're seeing you for lung disease, we want you to stay on the medication regimen that's keeping you comfortable, because comfort and quality is our primary goal. That's a great question, Deborah. Joe, does a neurologist or PCP certify a patient for hospice? So the actual physician that certifies you for hospice is the hospice medical director. However, information from your PCP and a neurologist or other specialist physician helps us with that decision-making process, and also then helps us build the case to Medicare. These other physicians, neurologists, PCP, are in agreement with our hospice medical director that this patient is in a progression of the disease that would allow us to care for them. Let's see, Carol, I was a Parkinson's care partner for many years in Latrobe, and my guy was on hospice with Excella, and it was very helpful. That's great to hear. All hospices, as I mentioned, are federally administered programs. So everything that I described to you today should be described to you by any other hospice you may talk to in the future. And I think that I always tell people who are maybe interviewing my hospice and another hospice and another, I always say the best decision you can make is to use hospice, first and best decision. And truly, the nurses and those providing care in the field are wonderful people. It's almost impossible. I've met very, very few hospice nurses that I didn't jive with. They're incredible people. And so you're not going to go wrong no matter what decision you make. The most important decision is to just utilize the benefit. Great point, Karen. Antibiotics are comfort. Yes. There are many people sign off on the pink post form or other forms, and they say, oh, I don't want any intervention, meaning antibiotics. And I would never suggest that to anyone. If you have an upper respiratory disease or a UTI, that is incredibly painful. It can be really, really difficult to manage when you are also in pain on top of an additional, disease, an additional virus on top of that. Nobody wants that. Nobody wants to feel uncomfortable and not have a curative treatment right there. So I don't want anyone to think that by denying curative treatment, we couldn't use antibiotics or other medications to make you comfortable. What we're looking at is, if there's nothing that we can do interventionally with neurology, there's nothing we can do to intervene with cancer disease progression or cardiac disease progression, that is accepting that there's nothing curative that we could do. But could we use curative medication for things like a virus here or there, or infections here or there? Absolutely, and we should. Thank you, Karen. That was great. Joe, I see your question here. Who certifies them? Oh, no problem. So the hospice medical director is truly the physician that certifies the case, that truly certifies that the patient is in the disease terminal in that process and would benefit from the care of the hospice team. But information from the neurologist and the PCP help us build that case and help the medical director build that case. Nikki, great question. Would therapy be not something that the patient doesn't receive? So some therapy is curative, okay? And I completely agree with you. But in the case of a patient coming onto hospice, we know that home health therapy isn't going to get them up and running marathons again. But if we can get them to a max functional level that allows for their caregivers to provide better care for them to move safely around their home, or for them to have some other justification of quality and comfort, then we're certainly able to bring some home health therapies into the home to support the patient and the caregivers. Even some speech therapy, although speech is fairly limited when it comes to hospice, because by the point that we're utilizing that, if you want to have a pureed diet, that's fine. But if you want to utilize a different diet and eat what's comfortable to you or drink what's comfortable to you, that's okay too. But you make a great point. There are some times where therapy is considered curative, but the way that we would look at it is, does it add into the patient's overall comfort and palliation of symptoms? And does it help their caregiver provide better care for them? Then we're able to justify the Medicare. That was a great question. Any other questions, you guys? These are wonderful questions that you're asking. Great question, Karen. The average length of time that someone spends in a patient's home. So that's an interesting question, because there's two answers. I can give you two answers here. The nurse and the aide have to be providing what we consider a skilled care, meaning checking a patient's skin, listening to their lungs, providing a bed bath or a shower, helping a patient bathe, setting up medications, discussing with patients what we're going to do next and what to expect, and discussing with families. The nursing and aide visits take about an hour. It is not, it's not an at-home continuous service where they provide their care and then they are able to sit for 2 hours with the patient and support them. Although I will say there are times where they will tell the caregiver, hey, go ahead to the grocery store. I'm going to be here about an hour, hour and a half today. Go take your moment, get your hair done and come back and I'll be done. You know, I'll leave as soon as you're back. But where we have a little bit more wiggle room and length of time is with the chaplain and the social worker. There were times where I, as a social worker, would have great conversation with patients, as I mentioned. And there were times that my patients didn't want to talk and we watched Hogan's Heroes and I sat and supported them and we talked a little bit here and there and build our relationship. There were also times where my patients would generally be asleep during visits, especially in nursing facilities or in the hospitals. And I would read passages of scripture from whatever, if they were Catholic or Christian, from the Bible, from whatever religious text that's important to them, and play music that would be important to them, you know, regarding from their religious background or something comfort that they like. Let me see your question here, Karen. So depending on the circumstances, there is a little wiggle room for respite for the caregiver to do errands. Yep, a little bit, absolutely. And that's where our volunteers come in, is if I can get a volunteer to come in for 4 hours so that myself as the caregiver can go out and get my hair done or just go out and take a breather, it's incredibly important. So we really work closely with families that need that and really need that support and get volunteers into them. In addition to building that out. So I might say, hey, volunteer, what day are you going this week? So I can do my visit an hour before you go. And then when you get there, I'll move on to my next visit, as my next social work visit that I need to get to. So then the caregiver gets 5 hours or 6 hours. Can we add the chaplain in there? You know, and we do that to build that out. But that's a nice thing about our team taking an IDT approach to patient care, is that we as a team can say, oh my gosh, Mrs. Smith really needs a break. Can we all coordinate our visits for one day this week, and then nurses and aide continue visit throughout the week, but can we all make sure we're visiting Wednesday so she has a bulk of time to get out of the house? Okay. And Nikki, I see your question here. Is there any help you can provide for a caregiver taking care of someone who is incontinent? It's a great question. I think what you're probably asking is what can be done after the team has been there. We've cared for the patient, they've had their incontinence episode, we've cleaned them up, care for them, and help them into dry clothes and a dry brief or whatever that might look like. What else can we do? The best thing that we can do is train a caregiver how to properly care for patients. But unfortunately, hospice can't be the, oh, hey, they need their brief changed again, could you come back? It can't really work in that way, because we can't justify to Medicare that is truly the primary goal of our care to patients. But what we can do is supply all of the equipment for you needed to take care of someone and train people how to do it really quickly and effectively. And our social workers can help look at finances and look at any resources that might be available, whether it's the waiver program to provide aids in home or finding private duty care that might help patients at home. Oh, Carol, interesting. A nurse who found herself too attached to my guy and have someone step in for coverage. That can be difficult at sometimes, you know. Hospice is a really emotional job. A lot of times my friends tease me, I watch very silly TV programs and they'll say, why do you watch that stupid stuff? And I'll say, I've spent all day talking to people who are in a terminal disease process or are about to sign their loved one on to hospice care. And that's a heavy decision to make. It's a heavy conversation to have with someone. I try to be present and give my energy and time to people in that conversation every time we have that. And there are days I have that conversation 5 times. So I need like bubblegum for my brain when I'm done with work at the end of the day, because I've spent a lot of mental and physical energy providing care and holding space for patients and their families. The same can be true that nurses get too attached. I'm sorry to hear that that happened. I do think it's important to understand as a hospice care provider that we can be friends and build relationships with these people, but our job is to hold space. Our job is to hold space to allow them to grieve and process and give that emotional space to them, but not push too far beyond those boundaries. And I'm glad that you were able to find someone else to step in. Karen, you're 100% right. The body keeps the score. In fact, I had that quote in my head for some reason this week. So you must be a mind reader, Karen. It is important for caregivers to get help and take breaks. I can't tell you how many times I've talked to a caregiver on the phone and explained what hospice is to them. And they sit there and pause in their conversation and say, wow, you just read my mind. I needed this. I had no idea. And it feels like they were putting a puzzle together on their table and there was a missing puzzle piece and they looked everywhere. And here I pull up with the puzzle piece and I am able to stick that down in the puzzle and add into the puzzle of care for them, you know. And it's important to be able for them to say, wow, I can't believe the support I'm going to get. And this is super helpful now. Any equipment that could help. Nikki, is your question in regards to help equipment that would help with incontinence? Gotcha, thank you. So yes, if there came a point where a patient was incontinent or that the nurse would think that clinically it's important to utilize a catheter, there's something that we can do. There are certain different catheters we could use. There are internal and external catheters that can help with that. And there may be some other interventions that I'm not aware of since I'm not on the clinical side of things that we could work with, but there's definitely something there and the nurses could advise and help further with that. But I'm sorry I don't have the direct information to you on that. Yeah, Karen here sent a quick message that sometimes caregivers get sick after the recipients of care pass because the adrenaline, finally your adrenal glands are able to relax. You finally sit down and think, oh, and then everything sort of hits and you get sick. That's absolutely true. And that's why we have our bereavement team follow up with patients with families after a patient passes. It's incredibly important. Even if all they know is, oh, Rebecca called me again. Rebecca's one of our primary bereavement coordinators. Oh, Rebecca called me again. They might not ever call Rebecca back, but they see that Rebecca's calling and offering and having a conversation. They might call Rebecca and have a 2-hour conversation with her. That does happen and that is okay. And that's what's important for us. Yep, Joe, it's really important to honor patients, especially the patients that we care for in Pittsburgh. I know I mentioned we have other religions that we care for, and it's important for us to honor those. I would say about 95% of our patients in this area are Catholic or some stripe of Christianity, and all of our team is comfortable being able to speak a little bit directly to that and being able to share with that, even if that might not be their religious bent or their lean religiously. We're all able to help that family and that patient sort of speak that language to them. And we encourage, if that's important to that patient, to read scripture and have it read to them, to pray with them, to hold their hand, to pray over them or anoint them. Those are important things for us to provide and to do with them. Now, for our folks who are Catholic, our chaplains are not all Catholic, but what we do is work very closely with the different parishes in the area to make sure we're able to get the sacrament of the sick to our patients. So we always, and I'll even see sometimes if a family hadn't had it done, I've helped jump in to make some phone calls on, of course, a Friday afternoon. It's Good Friday. We're calling around everywhere we can find to find a priest to come help us. There's always someone willing to help, even if it's someone we hadn't worked with before. But it's really, really, really important for us to honor those cultural traditions in patients' religious choice. It's super important. And yes, we want to make sure that we're sharing that scripture with them, playing music for them, and of course, encouraging families to lean on that if that's important to them. Thank you, Joe. Well, thank you all so much. This really, truly has been wonderful. I'll do one last call for questions or comments. I will also share Casey has all my contact information. If you reach out to the Parkinson's Foundation of Western Pennsylvania, they will certainly be able to connect you to me. I'd be happy to engage any questions, conversations, even if it's a one-off question and you think, oh, she wouldn't want to hear it. I am always happy to chat and talk about hospice. I'd be able to, I'd be happy to chat with any of you at any time. Okay. Thank you so much. And Casey will have all my slides. I'd be happy for them to be shared out. And I know that this will also be on YouTube to go back and reference. Okay.
Thank you so much, Molly. I will be sending all of you a follow-up email with the presentation, slides, the recording, and also a little evaluation. This was excellent. Thank you, everyone. Have a good
Thank you
afternoon.
guys. Have a wonderful afternoon. Thank you so much, Casey.
You're welcome. Thanks, Molly. Thanks, everybody. Bye.
Thanks, guys.